Attention, attention. All units report to your favorite podcast stat. This is That's So RN, where we decode the chaos, call out the cracks, and care a little louder. Let's scrub in. Oh my goodness. Welcome back, healthcare fam. It's your girl Lolo, and you are tuning into another episode of That's So RN. Today we will be discussing something I feel very strongly about, and that is patient ratios. Patient ratios. So, when I am referring to patient ratios, I am talking about the number of patients a nurse can have on the floor for their assignment for their unit, right? Keep in mind, anything that I'm reading, any numbers that I'm giving y'all today is specifically related to the state of Louisiana, where I am currently housed. So if you have a state that you are listening from other than Louisiana and want maybe more specific numbers or to talk about it, just let me know in the comments or shoot me an email or leave an answer in my Google Doc link, and we can try to set something up to get something a little bit more personalized for you. Now that we know what patient ratios are, we can kind of talk about them in more detail as far as numbers. So I most recently worked as a med-surg and telemetry nurse, and the max patients that I could have per my facility, is 6. So some other ratios and other places that we have would be med-surg. We can have between 6 and 8 patients. Tele step down, we can have between 5 and 6. ICU, we can have between 2 and 3. This is a little bit more critical care unit. So if the patient is bad enough, sometimes they will only have one patient. ER, 3 to 4. Labor and delivery, 1 to 2. And again, they are usually with, laboring moms. So I'm pretty sure if they are, I will have to re-up on that research. I read it, but I've read a lot of things since then. I'm pretty sure though, if they have a laboring mother, that they just have that patient and that is their sole focus, and that is the only patient that they will have for the duration of their shift. And then psych, 12 to 16. As a med tele nurse, being that I have had 6 patients, to go and hear that other departments, most specifically psych, can have more patients, I was flabbergasted, and I could not even imagine taking more than 6 patients. So Louisiana is one of the many states that does not have a nursing ratio mandate. The only state that has that, I believe, is California. They have a maximum and a minimum amount of patients that they can take, right? So remember them numbers I just read to y'all. I'm going to read y'all something from the American Nurses Association. So, according to the American Nurses Association, they recommend about 1 nurse to 4 patients for med-surg, 1 to 2 in ICU. Louisiana's actual ratios are usually more than the recommended amount, and they exceed the national safety benchmarks, posing risk in delayed care, medication errors, burnout, and turnover. Burnout and turnover, y'all. So I have a little story actually that I want to share. This is a personal story from when I was a baby nurse, just a baby, from when I was a baby nurse on the floor. So we at my facility give 3 months of orientation. You're with your preceptor, obviously usually a more experienced nurse, and you get your patient assignments with this nurse. For anybody who has precepted or been a preceptee, you know that even when you have your 6 patients, when you're with your preceptor, that is not the same as when you are an independent nurse on your own. And when I say on your own, I just mean doing everything by yourself and not having somebody immediately there at your beck and call to be like, hey, this is what's going on. Yeah. Right? So I worked with my preceptor very closely, and we started me at one patient, like you should, and we worked our way up through the weeks. Now, when we got to our six patients, or when I got to my six patients, we would then the next weeks come back down to one. I got into a little groove and I'm like, okay, this is nice. We have our six. I probably won't need to have six all the time, but if I have six, I can manage it, right? Fast forward to I get out of orientation. I get out of orientation. We are having some staffing problems with the night shift. So we have to move a few beds to other units just to be able to have the 1 to 6 ratio. We move the patients and I get my load for the day. In my patient load, I have 4 total care patients. For those who don't know what a total care patient is, it's exactly what it says in the name, total care. You have to do everything for that patient. You have to feed them, bathe them, clean them. If they need to be mobilized or need help mobilizing, like you have to do everything for them. So 4 of my patients were total care. 3 of my patients had a peg tube. For anyone that does not know, when you have a patient with a peg tube, if they're requiring meds and things to be put down this tube, it takes a little bit longer because you're having to crush the meds, flush the tube, make sure you're obviously not overstuffing them with additional water and things when you're flushing, but making sure you're not clogging the tube, just other precautionary measures that you have to take when dealing with these patients. So on top of my 4 total care and my 3 with pegs, one of my patients was just not happy. She was ready to go home. She was calling me every name in the book and cussing me out for a month of Sundays. I was everything but a child of God to this woman, and she was just giving me a hard time on my shift. Once I did my initial rounds, I was like, okay, I see what my patient load is looking like. Let me try to get my meds together. Let me get myself organized on a system like I was taught in orientation, right? So the secretary calls me and she's so sweet. She calls me to the desk. She's like, hey, Dr. So-and-so is on the phone for you. Like they need to talk to you. I was like, okay, like park it. So put it on hold. And I'm going to go around the little nook that we have to the backside of our nurses station is where the doctors kind of dictate and do their thing. I was like, let me get around there and I'll pick up the phone, right? And talk to the doctor. As soon as I stepped around in that nook, I literally bust out crying. I bust out crying. I was like, oh my God. I literally started freaking out. I was crying because I'm just stressed and overwhelmed. I'm like, oh God, there's only 3 nurses up here. I'm one of the 3. I can't just be like, hey, go get your preceptor because your preceptor's not here. You have to do it on your own, right? So I'm in the back, I'm crying, I'm trying to gather myself. And I know me personally, sometimes I just need to cry it out, get it all out my system, regroup, and then I'll be able to do what I need to do, right? So I'm crying. Y'all, the secretary comes around and she's like, are you okay? I was like, yeah, I'm good. I just need to get this out of my system, right? Y'all, this woman goes around the freaking desk. She goes around the desk and she gets on the overhead pager and she's like, hey, is there any nurses available to come to the nurses station? Logan's up here crying. I'm like, ma'am, why are you telling my business? And why are you making an all call? Like this goes into the patient's rooms and everything else. Why are you doing all that? So they come see about me and they're like, hey, like, how can we help you? What's going on? And I'm just like, my mouth is open and I'm not telling them anything. My brain is going 90 to nothing. I don't even know what to tell them to help me to get started so that I can get back on track, right? So finally am able to relate to them what I need and they help me. I get my meds passed, I get all my things done, I get my patients seen about, and I'm able to sit and chart. I already had it on my mind that I'm staying later. I had a delay in my schedule and things that I wanted to do for the shift, so I knew I was staying later off rip, right? So we get to the end of the shift and I'm like, the worst is behind me. I can chart and go home and not have to deal with this place until tomorrow, right? No. We had two people code at shift change. Two people. We are split up, the three of us running between the codes, trying to figure out what's going on, coding the patients, doing all the things. I think that was the first night of all the days that I had worked that I got off that late and that I literally rode home in silence. I just heard my tires slapping the gravel and the pavement on my way home. I was just over it. My brain, my body, everything like shut down and was like, I was not, I was, I disassociated so bad. Like I disassociated. And we want to, as nurses, be everywhere all the time, get all of our things done. And I think a big part of that is them stressing to us that we have to take this amount of patients. That's the most we can take. And we have to do things by a certain amount of time. So I was really just feeling the pressure and really was like, should I be doing this? Should I even be a nurse? I did all the stuff I needed to do to pass NCLEX and be on the floor. And I felt like I had a pretty good grasp, of that for the time being with me having started and working my way up to those patients. But it did not feel like that once I got on the floor. So I say all that to say we have these ratios and sometimes it really can be a lot. It doesn't necessarily always feel like it is, but then we go through something like that and we're like, okay, how could we have prevented this? Is it because we had too many patients and we had too much to do that we didn't catch these signs and it ended up being, the codes and all that at the end of our shift? So that's just some things to kind of be mindful of and keep it in perspective. So the national average of nurses to patients is 521 nurses to 100,000 patients. And in Louisiana, we have 368 nurses to those 100,000 patients. So that's a huge gap, a very huge gap, and would probably explain why we are having some of the issues we are having. So now, why are these high ratios causing a problem and why are they hurting us as nursing staff? Firstly, and we are big on patient care, right? They are causing patient safety risks. The less people we have to attend to these patients, or the more patients we have with the more problems with not enough nurses or people being pulled in multiple directions, we are running the risk of med errors, infections, pressure injuries, sometimes even death. That story I just told y'all with the code, one of the patients did end up passing. And again, it really just makes you sit and think, what could we have done to prevent that? Or maybe if I wasn't doing this, I could have caught it sooner and kind of intervened before it got to this point. So things like that. And then nursing burnout and turnover. I always hear people fuss about the shortage with that, which that is a whole other episode. But I always hear people fuss about the shortage. But working under these conditions with this many patients and having to do these many tasks is really causing people to just either take a step back or leave the profession altogether. And that causes a problem because we're not able to replenish and get those people back in as quickly as they're leaving out or changing to do other things. I hear a lot of people nowadays in 2025 talking about their soft nurse life and jobs that are not as strenuous because so many people complain, or maybe they've worked on the floor and they see how bad it is. I see a lot of our veteran nurses. I was just talking to one of I call her Mama OG nurses the other day about the patient load. And she's like, I would have been able to run circles around y'all back in my day with that amount of patients. 6 patients is nothing. And I had to remind her, like, ma'am, stuff in the 1950s and 1960s is not the same as it is now in 2025. The patient acuity is way higher. And when I say patient acuity, that's just how much a patient requires to care for them. So we're getting the sickest of the sick patients. We are getting multiple sick patients that require a lot of things. And it's not just, oh, this patient's here for, renal issues. Like they're having a consortium of problems that we're having to try to troubleshoot and manage. And it's not just one patient, it's multiple. So knowing that things have changed and it's definitely not the same as it was before. And then on the other end of that, we have kind of our new grads. I feel like we're telling them that they're going to potentially have six patients, right? When I was coming in on the floor, I was told that I would have six patients, but I don't think we are being properly prepared for that. I mean, for example, in clinical, we're not even seeing six patients or managing six patients. We're managing maybe two at most, and that's with our nursing instructor, or we're sharing it with another student, right? So just properly preparing those people when they're coming in so that they can take care of the patients. So, what are some things we can do to kind of combat and fix these problems? Firstly, I would say model our ratios after, the recommended things that federal and national agencies are telling us. I know at one point we did try to do the lesser ratio thing. I was very appreciative. When I had my 4 to 5 patients, baby, cakewalk. I could do my charting, I could pass my meds, I could see about my patient. My patient was lathered up, bathed, fed with the nice swoop bang and updo by the end of my shift. Everybody was taken care of. There was not anything that was ever left undone or pushed to the next shift. But the problem was it didn't last for very long. And another problem with it not lasting very long is when it came back into play that we had to go back to six patients. It wasn't, hey, just so you know, we did try this, but because of the acuity or the patient volume, we're having to go back to six. It was kind of just like, okay, I had my 4, came back one shift, was 6, came back the next shift, it was 6, again, 6. So just no really transparency with that. Another thing we can do to kind of help fix or, make it better or address it is kind of beef up or bolster our recruitment and retention with, addressing problems like pay, workload, i.e. the patient load that we're getting, and work-life balance. I feel like I come to work and work like a dog just to barely get PTO and not have anything to use. I feel like I will work 40 days and 40 nights before I will even accumulate an hour. Sometimes it feels like, or if I need something, because it's just so much and we don't have enough people to fill those gaps, we're having to essentially work or be punished if we can't come in or do things of that nature. There has been a really big controversy lately, going back to pay, within my organization on incentive pay and them going down on the amount of pay that they're giving for people working extra or picking up extra shifts. So people are more likely to not do it with that. I've heard a lot of chatter and complaints. Oh, well, I already work my 12-hour shift and they aren't paying me, but you want me to come work extra because we don't have the amount of people that we need and I'm not getting paid for it. So just things like that. Also, something we can do is just be transparent. I know things are not always fixed in a day or 2 days or even a couple of weeks. Just being open and transparent about that and stating that, hey, I know that we've had a lot going on and I know that you guys want a certain thing or certain ratios. We are not able to do that right now because of XYZ. Being transparent and proactive up front instead of waiting for people to complain and be like, hey, you said this, we're doing this now, and now it's an uprising and it's a whole problem, right? A thing that they've done recently that I really am appreciative of is executive leaders have been rounding and doing 4-hour shifts on the nursing units. I think that is such a big deal and such a great thing that all places should implement. The only problem I have with that is in any instance when an executive leader is on the floor or coming to see about us, what are we doing? We crossing our T's and dotting our I's. There is not a problem on the floor. Everything's fixed. Everything's good. And we all lollipops and rainbows, right? No. When your executive leaders are on the floor, y'all, this is the time for them to see everything literally falling apart. Everything on fire, stuff's not getting done, stuff having to get pushed to the side. I don't know if anybody has seen that episode of SpongeBob where he forgot his name and his in his brain everything was on fire and there was multiple little SpongeBobs running around. They're like, "What's his name? What's his name?" And everybody was just in a panic. That is what they need to see. I feel like we're so used to normalizing the conditions on the floor, and we're like, "Well, we got it. We've been managing it. We've been doing it this far and for so long, like we got it under control, right?" We're so used to normalizing it that it's just like no big deal at this point. And it's just like, no, that's what they need to see. They need to see, because if they come on the floor and we're having these problems and we're expressing this, and then they get there and they're seeing firsthand kind of what's going on, and they're like, oh, well, this isn't matching up to what you said. I'm going to take it for what it is in front of me, right? They got it under control. There's no problems, no changes. True changes need to be made because everybody's doing just fine. So that can look good. And as a person that has worked and seen that, I always try to make it known that we are having these problems. So if anybody's watching this in management, upper, whoever, please know that we are doing this to make it look good. It is not good at all. You guys definitely are not seeing the real raw of us on the floors, what we're going through, all the things we're dealing with. And even though some of y'all do have nursing backgrounds, nursing has changed in the last 10 years, even in the last 5 years. And you guys definitely should be doing, you know, a side by side with us. And when I say side by side, I do not mean a shadow shift. I want you to work a 12-hour shift with me, chart, do all the things, take take 6 patients, see how I feel having to pass meds by 10 o'clock, patients going down for procedures, pain management, other things going on, ambulating the patient, cleaning the patient, feeding the patient, and let that really be, your perspective. We're so big on patient care. You definitely need to see it real and raw. And I know that probably might take a lot for nursing staff to get to because they want to make it look good for them and want to make it seem like everything is copacetic. But yeah. So some solutions that I have for this would be mandating ratios and actually having some sort of policy or something in place stating this is the maximum and the minimum that a nurse can have. I feel like if we do that, it will reduce the burnout and the turnover. People will be more likely to pick up and help if we aren't able to fill that need for staff as quickly, and the patients will get better care. They won't have 50 billion nurses rotating through here. It'll be better continuity and lead to better patient outcomes. Next, I would say including staff in any public reporting or committee decisions regarding staff. I feel like it's very easy for higher up or executive leaders or even managers or OCs, which is our operations coordinators, like our charge nurses. It's very easy for them to make decisions about things when they aren't necessarily in the brunt of everything. That's why I go back to that shift and them working side by side with us, because that will put it in better perspective. I feel like anytime any decision is made for nurses or nursing staff, I feel like they should be included in those decisions. We're living it day to day. We are doing everything firsthand, and we are really just, going to give a different perspective as somebody who's just getting the complaints and making the decisions for us without actually living through it. I really love, I'm not going to say her name, but she'll know who she is when she sees this. One of the managers at our organizations, I absolutely love. She is just so vocal, and she's a great person and a great nurse. And I love that as a manager, she gets on the floor with her staff and she works with them side by side. She works with them side by side. She will pull a shift with them and she'll be like, hey, I'm not a manager today. I am just a nurse and I'm here to work with you and go through that. And I feel like that's why she is such a good leader, because it puts things into perspective for her and she's able to be relatable on both levels because she's been there with us. She's been in the trenches with us. She's gone through all the things with us during a 12-hour shift from a peer standpoint. So you know who you are, girl. I love you. Keep doing that. Keep being you and kind of just putting those things into play. I'm hoping to eventually later down the line bring her on the show and just kind of brag on her a little bit more. But just things like that can make a huge difference in, transitioning and making changes and seeing things from the worker's point of view. All right, so next thing I want to say is a little controversial, and I don't like talking about politics. But recently we did have a big bill pass, so the dynamic will probably have changed from this aspect. But tying Medicaid funding to staff, I don't know really what that will entail now that this bill has been passed, but maybe later down the line we can kind of talk about it a little bit more once we get more details and see who it's affecting, how it's affecting them, and what we can do to kind of mediate the issue. So I done ran off a bunch of numbers to y'all, right? I done ran off numbers to y'all. I done ran off stories. I done did all the things. Why does this matter? Why do these things matter? They matter because proper care of patients is what is important. We are big on patient care. The patients, without them, we wouldn't have jobs. We wouldn't have anything to come. They are why we do what we do. So to ensure that we have impeccable patient care and just care for them and the community around us and continue to grow in that aspect, that is one of the reasons it's really important. Shifting changes and allowing input for things like mandated bills, speaking up and using our voices, that is why it's also important. Closed mouths don't get fed. So if we're not speaking up on the issues and pushing for that change, it won't matter and it won't make a difference. So that's another reason why it's important. I always laugh because I can remember one instance where we also had problems on night shift with staffing. So we had to, again, try to move beds. But this particular instance, we could not move beds. They were calling managers, directors, upper management. They were calling everybody, trying to get people to come in and just take the patients until we could transition and move those beds. And they were trying to offer for us to take more patients. Mind you, I'm like, I had worked a 12-hour shift. I already have my max of 6. You want me to take more patients? Just not being, putting us in a place where we're not getting put in those situations to where our license is on the line. We're compromising patient care. Just instances like that are things we keep in mind on why all of this matters. And y'all know me. I was like, pause, pump your brakes. I'm not taking any more than 6 patients. I was like, I literally will quit if y'all try to make me take more than 6 patients. Ended up not quitting, obviously, but sometimes you got to put your foot down. So just knowing that we need to speak up, because this will push organizations to put actions behind the things that they're telling us. And again, even if we can't fix it next day, next couple weeks, next few months, next couple years, giving me a timeline or giving me an estimate and relaying that to me, and not just making the change without anybody knowing or without me knowing until after the fact. So I kind of wanted to shift gears and go into our next segment of Mind Shift. So today's theme is joy in the small wins. And the task, it will be a journaling prompt. What does joy in the small wins look like in your daily routine? Could you be more intentional? That is something for you guys to think about and get back to me with your answers, or something that you can just ponder on for yourself. On next week's episode, we will be diving a little bit deeper into documentation. What's the deal with documentation, all the changes that documentation has made over the years, and why that is affecting the healthcare industry. All right, guys, until next time, thank you for joining me and have a great day. Toodles.